Hello, everyone. My name is Mike. I'm a physical therapist and your host of the Health Me podcast. Thanks for tuning in, and remember to leave a like and subscribe so you don't miss any updates. We are back with another episode for you today discussing how the physical therapy profession is using wearable technology to improve patient performance and recovery. This week's episode, I had the pleasure of sitting down with the head of clinical sales at Dorsavi to discuss how the company has advanced over the years and how they made themselves distinguished from other wearable technology. Dorsavi is revolutionizing wearable sensor technology, providing therapists and providers real-time data and information about how their patients are actually performing. Our episode will highlight details of the technology used to measure patient performance, how that data is translated in the clinic, and how clinicians have utilized this to dictate exercise selection. Furthermore, we go over the importance of language and communication in the application of this technology, and how we don't want this wearable technology to become another MRI conundrum. Lastly, we discuss where the company plans to go in the future and how you can find a clinician using Dorsavi today. As always, timestamps and links for everything will be in the show notes, and be sure to stick to the end for the Health Me to Health You portion of the podcast. Please enjoy my conversation with Joanna Goldin. So I think a great way to start this podcast today would just be discussing maybe the background story of Dorsavi, but also the origins of wearable technology and physical therapy. I think nowadays everyone thinks of wearable technology like on your wrist, as well as other things, maybe a heart strap monitor or something like that. But when did this kind of era of wearable technology begin?
Yeah, so that's a very good question. So Dorsavi's origin started actually about 15 years ago. So we're actually an Australian-based company, and we're invented by an Australian physical therapist, Andrew Ronke, who's actually still our CEO to date. And he is a physical therapist that really wanted to find a better way to get objective data on his patients. And luckily, he had a very tech-savvy brother. And between the two of them, they decided that wearable sensors was the way to do this. And so there are lots of different motion capture ways to do things, but they decided that wearables, and you're absolutely right. A lot of people think wearables, Apple Watch, Fitbit, heart rate monitor, but we've sort of crossed over into the medical world of wearable sensors, which is a little bit different from a lot of other things. So Dorsavi started about 15 years ago in total infancy. We've really been commercial for about 10 years, and in the US for about 7 years now. And I think really wearable sensors in PT, we sort of led the way a little bit. There are a few other things out there now, but that's about the time frame that, we started looking at it and how Dorsavi kind of came to be.
Certainly. And in the beginning, it had to be kind of scary, not knowing what the future held or if this was something that was going to work later down the road, right? It was something that was kind of
Right.
new,
Right.
8 to 10 years ago. What was it like maybe in the beginning trying to get physical therapists on board to get wearable sensors on their patients and start using it?
Yeah, I mean, I think it's, I'm a physical therapist, so I can say this, but we tend to be a bit of a tech phobic lot sometimes. So you definitely have to find the people that love technology or are early adopters or want to do something different and want to go outside the box. Luckily, physical therapists, we're always striving to get our patients better. We're always looking for new things. And so, we do have a decent market of people that are like, I want to do this. And I always tell the story of how if I go and do a demo in front of a group of clinicians, there's those people whose eyes just light right up and they're like, oh my gosh, this is it. This is what I want. I've been waiting all my life for this. And there's the other group in the back who are like, oh my gosh, is that technology? Because I don't really do technology. So, as physical therapists, we're becoming better at technology, but certainly you've got to find the people that really want to put that on their patients and are looking for something different.
Was that your first experience with Dorsavi? What was your first experience? Was your face like, oh my God, technology, or was it like, yes, this is something that I wanted to, include in my clinic?
Yeah, so it's really interesting actually, because the first time I saw Dorsavi, I actually I'd moved to New Jersey. I had my own practice in Colorado for a long time, and then I moved to New Jersey, and I was sort of looking for new ventures, and I happened to be introduced to Andrew Ronke, who's our inventor, and he was in New York for some meetings, and he came out to my house in New Jersey, and he showed me the technology, and the first thing he showed me, well, not one of the first things, but the thing that really just got me was he showed me this case study of it was an athlete returning to play. And it was actually an Australian rules footballer. And he'd had a very nasty fracture of his lower leg. And they were just trying to decide whether he was ready to go back on the field. And so we saw a video of him running down the field. I mean, to the naked eye, he looked decent, I mean, not perfect, but you've got to make those decisions based on the naked eye. You wouldn't have said, oh my gosh, do not put him back on the field. But when they put the sensors on him and saw how much weight he had on one leg to the other, he actually had a 30% difference of load from one leg to another. In other words, he was offloading his injured leg by 30%, which obviously results in an overloading of the uninjured leg by 30%. So, you put him back on the field like that, you're going to have injuries on the other leg. So that was at a time when they said, no, you can't go back on the field. And then a week later, they reassessed him and he was at 13%. And then 3 weeks later, he went to 1%, back on the field, did great. And I was just mesmerized by the fact that having looked at that video of him running down the field, I was like, oh yeah, he might be all right. And then you saw the data. So that was my first experience. And then I started playing around with it. And, even as a physical therapist that's not young and just out of school, I can still work the technology. I figured if I could work it, anybody can do it. So yeah, that was my first experience. And it was just, I was just in awe of what it could do.
Well, for those who may be listening, maybe let's describe exactly what Dorsavi is. We've been kind of like hinting at these sensors and we've been hinting at this objective data that we're able to analyze and assess, but maybe just like at a 30,000 foot view, how would you describe what Dorsavi is as a company as well as a just wearable technology?
Yeah, so wearable technology, wearables, like we've sort of discussed, wearable sensors can be like your Fitbit or an Apple Watch. But we actually take these plastic sensors and we put them on patients or athletes or clients, and we put them in different locations on the body, depending on what you actually want to assess. So if you want to assess someone's running, we put them on the shins. If you want to look at their low back, we put them on the low back. The beautiful thing about our sensors is that they're totally portable. So you can take them from clinic to clinic or outside the clinic. You can go out and screen at an athletic venue, wherever you want to go. There's no wires, no leads. The data comes right off the sensors into the software, which is on a Surface tablet. And you also video at the same time. So it's easy to use technology. You can move it around. The other beautiful thing is that as soon as you've done a test, you actually hit the report button and get an instant report. So these sensors are, very easy to use, portable, and yet give you very accurate data.
And they're put in specific locations on the body, is that correct?
That is correct. Depending on the test that you're doing, and we have a variety of different, what we call modules, which is really different tests. So it could be a running test, it could be looking at someone's knee control, it could be looking at their low back range of motion, or it could be determining readiness to return to play. And then we put the sensors on different locations depending on what we're assessing. Correct.
And they're like these little sticky sensors, right? Like I'm trying to just, for people who are just listening, trying to imagine what this exactly looks like. There's these like small little white sensors that you put on the skin and they're just like, they stick to your skin, correct?
Right, that's correct. They actually go into a plastic holder and then we had a double-sided adhesive that attaches them to the skin. So they go directly on the skin, yes. But it's a one-time use adhesive that then you can just put on to the next patient. So yes.
And what was it like determining the areas to put the skin sensors on? I mean, there's so many landmarks in the body that we could analyze and view, but what was the motivation for certain landmarks as to where we should put the sensors? Because every time you put them on a patient, there's these specific areas that Dorsavi wants you to put them on, essentially, in order for you to get accurate information and that's reproducible, so to speak. And what was it like trying to determine, or at least what is the importance and significance of the same position of each sensor every time?
Yeah, no, I mean, just in terms of the exact location. So we've made it very simple that if you're putting them on the low back, we have a template that is based on someone's height that tells you exactly where to put the sensors on. On the shins, the tibia, we also have a ruler that tells you based on someone's height exactly where to put them. So from that standpoint, you want to make that reproducible, like you said. So if I go and assess the same person again, it's going to be in the same place. Or if someone else picks up the sensors and put them on the same patient, it's going to be in that exact same place. So your intra and intra-tester reliability needs to be very good. So that's the reason we had the templates and the rulers, partly to make it super easy, but also to make it very reproducible. Now, the research that was done, for example, on the low back testing, which is what we originally started with, we know that we need a sensor sort of at the base of the lumbar spine, which is the lowest part of your back, on the pelvis, and then we need a higher sensor at where the lumbar spine joins the thoracic spine. So all the testing was done, all the validation was done with the sensors in those locations. The same with the ones on the shin for the knee or for the running. Again, you need to make sure they're in the right place and also on the bony tibia, not in the soft tissue around it. But, you know, we do all kinds of training. And like I said, we've got templates that tell you exactly where to put them.
And it's important for those who may not be clinicians to understand, again, you said intra and inter reliability, which is just between subjects and so on. And what she was also describing is that, you know, everyone's a little bit different in size, right? A 6'8" athlete is going to look way different than a gymnast who's 15 years old. And so making sure that you have standardization, or at least the ability to place the sensors in the correct location, is really important, especially as you're tracking data. And, you know, how do you know, how is the data being collected from the skin? I mean, what is it measuring exactly? Like, what are these little sensors actually measuring? So that way you're looking at reproducible data.
Yeah, so we have two different versions of the technology currently, and the sensors go on the skin, and then the movement inside those sensors, for the physics-minded people, is a magnetometer, accelerometer, and a gyroscope. Wow. So all of that, there is yes, exactly. So that's about as far as I get because I'm a physical therapist. So luckily, most of the people I'm talking to are physical therapists and don't ask me a million questions about all the physics of what's in the sensor. Right. But some very clever people, much cleverer than I, software and biomechanical engineering people, figured out that you can get the data off those sensors. Now, our original version of the technology, the data just streams directly into the software, like no wires, no leads, no cameras, no nothing. And that uses ANT technology, which is what Garmin used. For those of you who are runners and use a lot of Garmin things, that's what Garmin used. Now, our newer version uses Bluetooth. Originally, Bluetooth wasn't quite quick enough, actually, but the newer version uses Bluetooth, and that's what we're going to use moving forward. So that data comes directly off the sensors. There's an algorithm in the software that then translates all of the data points into a report that I, as a physical therapist, can read, and even my patient athlete can also kind of understand as well.
And you can see the visible differences of, the way that your tibia is moving over your ankle, the way that your low back is moving in reference to your knee, and how these things are all changing all at the same time, which is really fascinating overall, just because, we can see it as therapists, and, we can just, it's almost like when you're looking at it as a therapist, you're like, oh, that doesn't look right. But then this is almost putting up like data to what, like that abnormality that you're seeing. Like when you see somebody walk kind of like different, they're not putting us as much weight on the left leg as you've been describing when you're running, you're like, that's not normal. But when you're using the data or the sensors, you're able to put it actually into an objective, like, oh, there is visible a difference between the left and the right, which is huge.
Yeah, no, it's huge. I mean, as therapists, we're very good with our naked eyes because that's what we've always done. And I can look at someone squatting or hopping and see, oh, that looks terrible. But to then be able to say 3 weeks later, how much improvement have you made? Now, I think as physical therapists, or any kind of movement or clinicians, you can often remember what they look like before, much to the patient's shock, because sometimes they're like, how do you remember what I look like before? But you do kind of remember that. But to have objective data to say you have improved this much, and some of the metrics that we can get, you absolutely cannot see with the naked eye. Mm. The number of frames per second the naked eye can see versus the technology is there's definitely a big difference. And sometimes I can look at someone squatting, like you say, and you say, that doesn't look right, that doesn't look good. But then I want to know exactly how bad it is. And that's where the sensor data can really see. And also it's totally objective. There's not me saying, well, that looks like this. It's literally, it is what it is. So
and have you been able to compare perhaps a therapist's vision on perhaps what they believe is going on and what ailments perhaps they think they see with a movement versus like what the data is actually showing through Dorsavi, and able to compare those two?
Yeah, we haven't done an official study on that, but oftentimes I'll, whenever you put it on a patient, and especially if I'm doing a demo on a patient or I'm showing someone, they'll say, well, I think this is what's happening with that person. Running is a perfect example. It's really hard to see the subtle differences of load change from one leg to another. And we look at videos and people are like, oh, they look pretty good. And then you see the data and you're like, first of all, there's a big difference from one leg to another. Secondly, how hard are they striking that ground? Which sometimes you can see, but not always. And people can be striking the ground really hard, or they can look like a decent runner. And then you put the metrics on and you're like, okay, this is where the problem is. So we haven't done a direct study, but I think anybody that uses it or sees the data is like, oh my gosh, this is so much more accurate than what I can see with the naked eye.
And I'm assuming people like in physical therapists are using this to basically prescribe exercise. And do you guys make recommendations based off the data for exercise selection, or is basically leave it up to therapists?
Yeah, I mean, it's a little bit of both, actually. You still need someone to interpret that data, right? So you'll get a result, but there's still clinical reasoning from the therapist behind what am I going to do with this person now? So the data assists in the clinical care, but it's not like, oh, this is what it is. We do actually, with the AMI, which is the Athletic Movement Index module, we do actually have a corrective exercise program that we can prescribe. So if you have a fault in the AMI, it gives you some recommendations, like say someone isn't squatting deep enough, or they've got too much movement of the knee on a squat or a hop, it will tell you what exercises to do. So we have developed that. I mean, technically, a lot of physical therapists are just going to do what they want to do because they know exactly how to treat that. It's just giving them a bit better objective data. And the very nice thing too is it also shows, like you said, like improvement from one time to another. So that's great to show your patient, and encourage them and tell them what's going on, and kind of encourage them to keep doing their exercises too.
Certainly. Was there a learning curve for you just analyzing all this data and trying to get into just the weeds of data analysis, basically, and then translating that over to a patient? You've been doing it for over 8 years now, so I'm assuming it's a little bit better for you. But at first, was there a big learning curve?
It's not a big learning curve. I mean, like anything, you need to know how to put the sensors on and work the technology first. So we do all the training for you, but the first thing we're going to do is teach you actually how to use the system. And then secondly, we teach you how to interpret it. So yeah, there is a little bit of a learning curve because these are not things that I've ever looked at before. I never looked at someone's ground reaction force because I had no way of measuring it. So there's a little bit of a learning curve, but we've developed a lot of like sort of normative data or ideas on what best case practice. So it's not a particularly steep learning curve once you've sort of mastered it.
And once you've collected all the data, where are you looking at all this information? Is like, can you look it on your tablet? Can you look on a laptop? Like what is the visualization device that you can see and manage all the data that you've collected?
Yeah, so we use, on the Movement Suite version of our technology, we use a Surface Pro tablet. And the Surface is very nice because it also has rear and front facing cameras. So you can actually video at the same time when you're doing the test. So then you can actually play back the video, because patients and athletes love to see that. Some people learn much better by looking at themselves because they just can't visualize what they're doing. So that software and the results are on the Surface Pro. Our professional suite version is on an iPad. So it's right there on the iPad. So as soon as you finish the test, you just hit report, you've got your iPad in front of you and all the data comes right up there. So it's very easy.
That's fascinating. And when you're building this out, what were the populations of patients who were benefiting from this early on, and then how has it grown as a brand? Because I can see how athletes obviously would use it, and like runners and people who are very active, but has this progressed into other areas, other populations other than athletes?
Yeah, so our original population was low back, and that's what Andrew really did. He did his PhD on the intra and inter-tester reliability. So the validity of looking at low back range of motion, just kind of with the naked eye. So we started with the low back. So if you think about all your back pain patients, so everybody with back pain gets really great range of motion. We know how far off you are, what the norm would be. So we started with that. So, most clinics see a lot of back pain patients. So that's very applicable for your, everyday outpatient clinic with patients with back pain. Then we developed into the knee, and the knee module honestly can be used for, from a sort of post-surgery knee to an arthritic knee to any, knee pain, anything in between. So very good for a very diverse patient population. So again, that can be used in like everyday outpatient practice as well. We also have running, and again, people who are doing running analysis love the running technology. So it could be that, but anybody that's got to return to activity, has to run. So you can also use it for your athletes that are, returning to sport that need to run. And then we most recently developed the AMI, which is really more for an athletic population. So, and people often ask me, so the AMI, it's the Athletic Movement Index, it's a battery of tests. How good an athlete do you need to be? And so I always say, like, sort of good high school athlete on up. It's a difficult, fairly demanding battery of tests. So not for everybody. But I think that, we get a lot of press for our athletic applications within sport, but actually the technology can be used in a very, very wide range of patients. So our clinicians and our clinics that are using it vary from regular outpatient practice to ones that have more athletes. Now we do also have a balance and stability module that can be used for an older population as well from the full risk standpoint too. So that does get some application as well. So really across the board. Now we haven't gone necessarily into some other realms of physical therapy from a neurological standpoint and things like that. But, general outpatient practice, yes, we have that covered.
And can patients wear it during a game? I mean, I think it's one thing to have a patient come in and they're doing a test in front of you and they're like, yeah, you look good to go. But then fatigue sets in the middle of a game and, maybe the environment's a little bit different. You're around players, you're in a high intensity game. Is there perhaps an ability to put the sensors on during a game so you can see what's actually happening during the event and when they're having pain?
Well, the quick answer to that is no. That would be absolutely ideal.
Right.
And there are some, you often see some of these things if you watch soccer games and stuff, they have some of those sensors in their shirts and stuff that tell you how far they ran and, all this kind of stuff. Some sports lend themselves to wearing that. Some sports, the athletes don't want to wear things during games. So, that can be an issue too. But the problem with our sensors and wearable sensors in general to measure movement is that they have a magnetometer, like I said, an accelerometer, and then the gyroscope. And the gyroscope doesn't love going in lots of different directions because it gets all, and again, more physics that's above my knowledge base, but it doesn't love it. So it's difficult to monitor all of that during a game. And I totally understand the argument because people say, well, they look great in the clinic, like you say. How is it going to be halfway through the soccer game? I mean, when is the time that most people get injured? Towards the end of games, usually if it's non-contact injury. So we do have the ability to potentially fatigue someone before you do a test. So that gives you a bit more of an idea about how they're going to go. I can also say that if you perform not well on any of the testing in the clinic, you are not going to do well out on the field with all the other factors that you just mentioned. So obviously, if you can get really good in the clinic and doing some of the other things, we do have, with the running, for example, we also have an acceleration deceleration test. Some of it for that very reason that you said, because people say, well, they did really well in the clinic and then they ran on the treadmill and they did great. But out on the soccer field, for example, they've got to stop and start. Now, they've also got to change direction. Again, difficult to get changes of direction. But we do have the ability to measure how they look in a deceleration phase and an acceleration phase. So that takes away a little bit more of the risk factors. But it would be ideal if we could put it on during a game and get every knee bend that you did and not yet.
Not yet, right. And that makes it seem like the importance of your testing that you guys use has to be crucial. And what you're doing every week or every time when you're measuring patients is essential. And when you're recommending clinicians to putting them on patients, do you recommend having perhaps a time when they're fatigued and a time when they're not, so you can compare those two data sets?
Yeah, I mean, I think that comes down to sort of clinical reasoning at that point. But yes, absolutely. And depending on what sport they're doing, some sports fatigue plays a much bigger factor than other sports potentially. So, but yes, absolutely. I would highly recommend that, especially if you're worried about that. And again, you've got to go back to the athlete. You've got to go back to how they look and how they were potentially injured in the first place to know, how should I really be testing this? But absolutely, you can absolutely do a fatiguing, whatever you want to do, have them run for, 20 minutes and then do it. Absolutely. Yeah. Make it as applicable as you possibly can to the situation that they're going to be going back to.
Well, it's an important point for clinicians too, if they start to adopt this, to make sure that you're testing as close as you can to that perceived event as possible. And I think in physical therapy, we often forget that fatigability is something that's really, really crucial to the overall performance of an athlete. And I think that uh, we're going to have to continue making sure that as wearable technology comes out, um, the collection of data is going to be only as important as the tests that you use. And if that test is in an optimal, like the first thing in the clinic, like you said, you're going to see the best version of that
Yeah,
patient. But if you get them in a fatigue state and that's when they start having pain, it's like, well, you never captured that if you only measure them on the front end.
absolutely. No, I completely agree. And I think that that is very important. And I think that, the situation that you do it in, I mean, again, all of those, you need to make it sport specific as well. So, and one of the other things about putting it on and sort of doing, because I get asked this question too, it's like, well, can I do any test I want with the sensors? Well, technically, if you know how to extract raw data and you're a really good, researcher, yes, you could. For the average clinician, that's just not practical. But one of the reasons that we do these specific tests is we have validated all these tests. So we know that this is accurate data. So we've validated everything to a very high level with Vicon. Vicon's like the gold standard for motion analysis. Vicon with MRI. We have FDA clearance. So we have to jump through a lot of hoops. So the tests that we have, we know are accurate and validated to a high level. So that's some of the reason that we do those specific tests, if that makes sense.
Are you guys constantly trying to adapt and perhaps implement new exercises or new ways to measure data so that way it's as applicable as possible? Because, 10 years ago, the standard of physical therapy is a lot different than it is today. And obviously things change. So are you guys constantly trying to adapt to new exercises selection?
Yeah, absolutely. I mean, there is, we get requests for everything all the time. Can we have the shoulder, upper extremity? Not yet. Can we just do walking with a patient? Yeah, that's coming too. So I mean, really, this is just the beginning of wearable technology. And we're always trying, and also some of the things is we're doing a lot of research studies with people who are using the technology, because we can get better at knowing what is the best score, for example, for a 14-year-old basketball player girl versus, a, I don't know, 30-year-old basketball male, or different heights. So we need some of this data and some of the research, until you are actually able to measure these things with wearables, you can't do the research. So, we're getting there. And absolutely, this is just the beginning, really.
What are some other things clinicians are saying? I'm just curious as to, what is some of the feedback that you're getting with them? Obviously, there's a lot of positives coming out of it, but also maybe some of the barriers that some of the clinicians are seeing out in the field and how that's progressed.
Yeah, I mean, some of the barriers can be, you need to obviously learn the technology, but that's like anything. As a clinician, if you go on any kind of continuing education class, you have to come back and practice it and be proficient, right? So yes, you need to learn it. You need to be able to fit it into your everyday practice, which sometimes is tricky if you have a lot of patients and very little time. I mean, we kind of know that's a bit of the reality, but again, that can be overcome because there is return on investment on this product as well for clinicians. So certainly you can use it that way. And I think interpreting the reports is not a barrier because it's really very easy. It's just making it, the barriers tend to be a little bit more like, why do I need this? Oh, once I see it, okay, now I want it, kind of thing. So, but we do get questions about when can we have the shoulder as a perfect example. When can we do other things, so, but we take all that feedback on and we're trying to get there. But again, it's not like if you just throw out a new shoulder test. First of all, the shoulder is extremely difficult because it's so many degrees of freedom and, so much movement. But we have to validate that and make sure that it's really accurate. So that's a lot of research on in the back end too.
So would you say Dorsavi at this moment in time is very efficient and good at measuring low back and lower extremity ailments in that regard? And the goal is to progress towards upper extremity and perhaps whole body, I'm assuming.
Yeah, I mean, the goal would definitely be upper extremity at some point. The goal would also be walking, because we can get running. We don't have walking right now, which would be great for a lot of different widen now our sort of clinical applications, because a lot of people post-surgery need to be able to walk well, post-knee replacement, post-hip replacement, things like that. So yeah, I think we're always looking at striving at, the next thing around the corner. So absolutely. I mean, on the athletic standpoint, yes, it is a predictor. The AMI is a predictor of lower extremity injury risk. and readiness to return to play. Having said that, I actually work in professional tennis on the side, and no tennis player, even if they had a shoulder problem, are you stopping at the shoulder? You need to look up and down the whole thing. So the application still can be there for many different sports.
And do you believe this wearable technology is going to start to elevate the physical therapy profession to higher standards? I think we still are trying to figure out the physical therapy profession. There's a lot of, groundwork that needs to be made. And do you feel like the wearable technology is going to start allowing for physical therapists to really, highlight that they know what they're doing and basically bring the profession up as a whole? Because I think sometimes there are physical therapists who claim to know all the answers, and it's like, well, we all have our biases. And so do you think this is maybe a way to kind of eliminate that?
I mean, I think it's definitely a step in the right direction. I mean, it's objective data. And I think it also helps some with research as well. Physical therapists, we've got a lot of people using our system, more than 80 people right now around the world using our system for research, because they know they can get objective data. And that's sometimes a problem with physical therapists and research. But it's definitely a step in the right direction, right? I mean, anything that we can get that, because sometimes we have trouble as physical therapists proving that what we've done is actually really effective. And we've got the subjective reports from the patients that say, yes, oh, I feel a lot better. I feel a lot better. But if we can have more objective data that says this is what we can do as a profession and help with clinical care, I think it's a win-win.
And I think that may be why, when you go to see a physician, there's like blood work, there's, tests, there's things that physicians can run, and people can be like, oh, well, that I feel better, the numbers say so. But when you go to physical therapy, a lot of it can be heavily subjective, meaning, do you feel better? And sometimes that can be influenced by the therapist of like what their perception and how they feel like the direction of your care is going. For instance, for those who may not be clinicians, if every time you walk in and, your therapist is asking, do you feel better? Do you feel better? There may be this like gut feeling that you want to just say yes, because they're like, you don't want to disappoint your therapist, and you don't want to, feel like you're going backwards. But sometimes it can be almost like overwhelming to have a clinician want you to get better and like almost like influence you to feel like you're better.
Yeah, no, absolutely. And I always make this comment because in other branches of medicine, like you say, there's so much more objective data, like your blood test or your MRI or your CT scan or whatever, which, again, we take sometimes with a grain of salt, but at the same time, that's perceived as objective data by the patient. And we as physical therapists, you're absolutely right. There's definitely some subjective overlay. And as a therapist, sometimes you do tests where you subjectively score people, and you don't want to upset the patient. Or, we're all nice people, so we don't want to tell them, oh, you scored terribly. So there is a bit of that. Whereas this is just sensor data. There's no overlay from me. There's no overlay from the patient. It's absolute objective data. And I think our patients are demanding some of that objective data. And I also say that, from the technology is amazing for clinical care, but it also, if you adopt it as a clinic, it sets you apart from another clinic because you have some objective data. So, don't just discount the power of the actual sensor technology itself from a data standpoint, but also from a marketing standpoint and how that can assist you in your practice.
I want to get back to the marketing idea, but I want to first highlight this idea of like language. And as pain science continues to advance and, more physical therapists understanding the importance of language, has Dorsavi tried to implement language in a way of conveying to the patient, how they're doing? Because again, you can have a patient come in and their left knee is like, let's just say not moving as well as the right knee. And you're like, oof, like this isn't good, and then like the patient's like, oh my God, my left knee's going to blow up if I don't like fix this issue. So is perhaps implementing language and discussing things in a way that is not negative to the patient part of what Dorsavi is trying to implement?
Yeah, I think that becomes that not necessarily our role, but it certainly is the clinician's role, because and we know as clinicians, every patient has a different personality. And some people, you can go straight up and tell them, this is terrible, you need to work harder. You say that same thing to the next patient and they'll probably never come back or just go home crying. Yeah. So, again, you have to know how to motivate people. We actually did a very recent webinar on which was one of our account managers, who's a physical therapist, our new tech support girl, who actually came from a market where she was using the technology a lot as an athletic trainer, and then Trent Nestler, who helped us develop the technology. And that webinar was actually geared at how to deliver the report from the AMI in a potentially positive way. Because, you know, I think that's really an individual therapist skill. But at the same time, if we can give you some cues on, look, take the report, let's show you the good things, and then show you and lead you in. But because sometimes people look at the reports, because sometimes the patient can look at the report and go, oh my gosh, this is a disaster area. And we're like, yes, but look how much you've improved from last time, or let's look at the high points or whatever. So I'm not sure it's completely our job, but at the same time, we are very experienced and have seen a lot of patients in a lot of settings. So we have some advice on that, yes.
And the last thing we'd want this to turn into is another MRI scenario where, you know, you're not necessarily your MRI when you go in, you know, if you get it, you get an MRI and you have a disc herniation, that may not necessarily indicate that that's where your pain source is. And so I'm assuming this has to be kind of in the integration and development of Dorsavi.
Yeah, I mean, it's a very good point. And I hate to use the MRI as a great objective measure, because we all know that, yes, everybody's going to, you know, you MRI everybody's low back and everybody's going to have something. Is that causing your pain? Not always. Now, again, Dorsavi and the interpretation of the results is still going to come down to a clinical judgment call, because I could put that on and have someone run and there's a 20% difference from one leg to another. Well, I don't just say, put more weight on the other leg, because you've got to figure out why is that, you know? So for example, someone could come in and say, you know, my right hip is hurting when I run, that's example, and you put the sensors on and you say, well, you're actually overloading that right leg by 20%. Now, again, what is the reason for that? Now, you find out that they had an ankle sprain on the left side 6 months ago. Okay, subconsciously, they've just offloaded that left ankle sprain and it put all the weight on the right hip. So, you know, the data will show me what the numbers are, but there's still clinical judgment and reasoning behind why that is. So, you know, we're not going to become robots here. It's, you know, there's still going to be the physical therapy is a mixture of an art and a science. So we still need to make sure that we're interpreting everything, you know, perfectly from the science and the art standpoint, and the patient's personality as well. So,
sure.
Yes.
Well, I'm going to kind of poke a bear here, because I want to ask, you know, is the ideal version of somebody having equal limb symmetry? Because perhaps you get injured and you go into a clinic, you get measured, and maybe at the end, said and done, you're still not putting 20% on the right leg versus the left leg. What if that was their baseline beforehand, and maybe that was just the way they walked since they were a kid? You know, how do we try? I know we're never really going to know per se, like what somebody's natural gait or natural cadence is, so to speak, but you know, how are we trying to get them back to their perceived normal? And like, how do we understand like what that actually is? Because you, again, like I said, if you had from birth, you had a 20% like weight bearing discrepancy, you put more weight on your right always, no matter what, and that's your normal. If you get back up to that normal, then you shouldn't have any pain ideally, but maybe there isn't. I guess, like, maybe just speak to that, I guess.
Yeah, I mean, it's a very good discussion point, because for the most part, I have not seen my patients prior to injury, for the most part. Mm-hmm. Now, there are settings where if you're working with a collegiate team, or you're working with a high school team, or I don't know, pro team, where you might do baseline testing. So baseline testing at the beginning of the year, you might know what that norm is. Now, so if the patient comes in, like you say, and they've had an injury, how do I know what you're basically asking is, what am I getting them back to, right? What is that? Now, there's a lot of discussion about this, because the thing is that, let's say they've had a knee surgery, or let's say I'm going to use an ACL tear. So they had an ACL tear, so they non-contact, all right? So there was no one else involved. They were just running down the field and they tore their ACL. Okay. Then they come into me. I've never seen them before. But when I do the testing to get them back on the field, we have some best case practice. We have some normative data. I don't really care who they are, whether they're, you know, David Beckham or a 12-year-old female soccer player. Their knee should not be going in too much, right? I mean, you know, if you're just standing there doing a squat, you shouldn't be knocking your knees together, right? I don't know whether they were knocking their knees together before, but I'm going to make damn sure when they go back on the field now, they're not knocking their knees together.
Mm-hmm.
Because the problem is as well, is that what they had before may not have been very good, right? And this always also comes back to, we used to use, and we still use it some, but there used to be more weight put on, like from an orthopedic surgeon sometimes, like, well, is it as good as the other leg? You know, is that surgery leg as strong as the other leg? Or is it as good from a control standpoint? Well, the problem is with that person that ran down the field and tore their ACL, the other leg, the good leg, may be an ACL waiting to happen as well, because I don't really know how good they were beforehand. So, but what I'm going to do is make sure that they meet the benchmarks to go back on the field and be as good as possible. Now, in your example with someone who, has always walked with 20% more weight on one leg than the other leg, well, we can say, oh, let's put it back to that. But that is going to be a problem long term. I mean, right? I mean, so I want to get them out of that as much as possible. So it is a problem because I don't know what they were like beforehand, but I want to make them even better than they were before. And I want them back to as good a normative as possible.
And I just want to
answer the question.
It 100% does. The point of the conversation is to just, for people to understand who are listening, that it's complicated. We're trying to figure it out as physical therapists, and we're trying to understand, but there's a lot of these barriers and these conundrums, as we're kind of highlighting, that what we're looking for is extremely nuanced, and humans are extremely nuanced. There's so much variability in the way that we move and we walk and we change. And like you alluded to, they may have had an issue. You might have an issue with walking prior to an injury, but that might not have been ideal. And you might, like you had said, there might be an injury waiting to happen. And so perhaps if you're a patient listening and you're going to a physical therapist and they're trying to work it out, be patient, because again, we're working with a lot of variables and we're trying to all figure it out and move towards a common goal. Obviously, it's to get you better.
Yeah, I mean, I think it's always one of the challenges with physical therapy because, we do research, but like you say, every patient is completely different. And we're not putting people in bubbles between treatments and between whatever. So yeah, how do you control all the variables that are going on? Very difficult. The nice thing with objective data is we can say, for example, our low back module has complete normative data. So if you are a male and you are 45, it tells you how much you should be able to bend forward and backwards and sideways and sideways. That's fairly easy data to collect in pain-free subjects. Some of the other stuff, we're going off the research on what is best practice and, what would be the best at that time for you. So yes, bear with us.
It's complicated. Yeah.
It is complicated. Yes. Very.
Now that you've been collecting data for so long, have you maybe established normative data that you can compare your patients to? If you've, over a population of patients, say you're only dealing with ACL and you have, boys and girls between the ages of, 12 to 18, and this is the, normative data that you're seeing for knee inclination or whatever. Have you been able to start to normalize some data from big data sets and then compare it for other therapists to utilize, so that way they know, like, am I doing the right thing? Is this exactly what the patient should be looking like?
Yeah, I mean, we're actually in the process of doing a whole bunch of studies on that. One of the slightly challenging things for Dorsavi is that when people use our system, it's their data, not our data necessarily. Right. So, that there comes a lot of privacy with that. So we don't necessarily have access to masses and masses of data sets. But there are independent people, Trent Nessler is one of them, who is doing a big study looking at normative data, exactly all of the data sets that they have collected. We're also doing a couple of retrospective studies looking at the tests, what people scored on the AMI, which is the return to play, and then what happened to them in the next 2 years. Did scoring really well prevent injury? You would hope so, yes. So we're absolutely getting to that. I mean, this is so new, and we need, because the problem with normative data, we know, like I said, whether you're David Beckham or a 12-year-old, your knees should not be knocking together, right? So we know that. But do we know, like, what is the best case practice of, someone, like you say, who's a 14-year-old freshman basketball player who's 6'1" versus the senior who's 5'5", that's where we need to get some more normative data. But there's still best case practices, right? You still need to have good control, whether you're, whoever you are on the sports field.
And even then, that's always changing, right? The athleticism of athletes between the ages of like 12 to 18 and the 80s might be completely different than the normative data of athletes between now, right? Like the kids who are playing a freshman probably could outplay most seniors in the 80s in basketball because of how, important sports has become in culture, and, how much the importance of just training has become.
Oh, completely. I mean, from when I played high school sports to now, it's night and day.
Yeah.
Yeah.
It's surprising.
Amazing.
Yeah. And now, are there ways for patients to find clinicians who use Dorsavi in their clinic? Are there, maybe you're a patient listening and be like, well, I want, the best objective data. I want to get involved and see if I have any limb discrepancies between my left and right when I'm running. Is there a way for patients to find out if a clinician uses Dorsavi in their clinic?
Yeah. So the easiest way is to go to our website, which is dorsavi.com. And there is a find a clinic on there, and you can just put in your zip code, and you can see an entire map of the US and see where the clinics are. So absolutely, it's all on there. If your local physical therapist does not have it, you could always suggest that they research it and look into it and contact me.
Do you believe the future of physical therapy continues to progress towards this more objective data? And do you believe that it's in the realm of skin sensors, or do you believe that data visualization, or at least data capturing, is going to come from other devices as well as the sensors that you guys have built out?
I mean, to answer the first part of the question, yes, absolutely. I feel like we have to go to more objective data. I mean, it's just the way medicine's going forward. And if we have it, why not use it? So, I mean, motion capture and 3D analysis. So 3D analysis is not just sort of, videoing with your, your smartphone, but it can be in many different ways. It can be sensors, it can be camera based, it can be, other things. That's fine. I don't, obviously Dorsavi we're using wearable sensors, but I think as physical therapists, we need to look at capturing more objective data. Absolutely. I mean, it's never going to replace the skill of a physical therapist, but it can only enhance your clinical decision making, really, at this point.
Basically amplify the physical therapist and what their ability to do, right? We're not trying to replace it and get rid of the therapist, more to amplify what therapists already do.
Yeah, absolutely. It's just another tool in your tool belt. And the more tools you have, the better you're going to be.
With that being said, what are you most excited about with the future with Dorsavi, physical therapy, and everything we've kind of been discussing today?
Yeah, I mean, we're actually sort of always bringing out new sort of tweaks on our current technology and new things. And so to me, that's super exciting, because it's just really the only way is up. I mean, it's such an evolution, and we're just learning as we go. So, to continue to evolve and to continue to get this in the hands of more physical therapists is obviously my goal. So I'm excited about that. I mean, physical therapy has come a long way since I graduated from PT school. And I think, we're a very, very smart profession. And, you have to be incredibly smart to get into PT school and to go through it. So, let's use those brains and just progress and get more patients better.
Well, having been in the physical therapy profession for so long, what do you think has been the most influential in changing the physical therapy space, would you say, in your own words?
Yeah, that's a really good question. I've been a physical therapist since 1983, which I don't even know how many years that is now, but it's a long time. Yeah. So, I mean, certainly wearables has changed things. I think, physical therapists getting more involved in research and doing more research studies, has changed dramatically from when I first started as a physical therapist. I mean, we really didn't have much research on whether what we did was effective. We knew it was effective anecdotally because we got our patients better. But I think the fact that we're looking at that and trying to prove ourselves as a profession and get more autonomy within the profession. I mean, it's an interesting one, because I come from England and I trained in England, and physical therapists have very, very high profile in England. Everybody goes to a physical therapist all the time. And I think we in this country need to improve that a little bit and be, seen as the first line of defense. I mean, patients should come to us first, which is not always possible. I understand that. Most states you have direct access, you can, but our physical therapists are so knowledgeable and can really help you right off the bat with a diagnosis, and then decide if you need to go and see, whomever as a medical profession. So.
And ultimately, what we would like for patients to do is to come in sooner to see us, because that will ultimately lead to more visits, more time, and perhaps just a larger effort trying to rehab and get back to where you want to be. Because if you, let's say you sprain your ankle and you have this thing that goes on and on for years and years, 10 years later, you come to see the physical therapist. It's like, well, if you came in 10 years ago, we could have started
Right.
working on this now. And now you got to spend an X amount of time trying to figure out like how to get better and all these corrective and all these ways that you've now adapted to that ankle that you sprained.
Yeah, no, I mean, earlier and even preventative stuff too, as much as possible. I mean, I think all of those things, just the physical therapy profession needs to do a bit better promotion sometime of all the things that we absolutely can do. You know, we really have so much skill and it needs to be out there.
And now part of this is going to be with Dorsavi collecting objective data. And I wanted to thank you so much for coming on the podcast today and just being so patient and answering all my questions. I know it's kind of to be a little bit test worthy there to try to get you to answer some of these difficult questions that are within the physical therapy space. So thank you so much for doing so. And we're getting down to the end of the podcast here. And this is going to be the health me to health you portion of the podcast where we discuss the same 3 questions I asked with everybody else. First question is, if you had the attention of everyone in the world for 30 seconds, what would you say?
Yeah, I thought about this question because I saw it come up. I would say, I mean, I would say you need to live every day and don't put off till tomorrow what you can do today. I feel this very strongly from, you know, family members and myself. It's like you never know what's coming around the corner. And so, you know, if you're thinking about doing something, do it and just make every day last, because appreciate every day. You don't know how long we have here on this.
And days seem to be going faster and faster nowadays.
Yeah,
so
absolutely. Sit and smell the roses sometimes. You know, that's my advice to the world.
Second question, what book do you recommend, whether a book you're reading now or in the past?
Yeah, so a book that I read when I had my own business that really changed the way I ran my business is called Good to Great by Jim Collins. And I mean, it's a little bit older now, but it is, if you have your own business or you're thinking about that, it's super easy to read. And it is a great way to think about, you know, the simplest thing is, do you have the right people on the bus for your team? And are they in the right seats? And I would think about that all the time with my staff. And so that's a really great book. I read and listen to fiction all the time. So most of the time I audio book in the car or walking or whatever. I read a really good book recently called Blue Skin Gods, if anybody's looking for a good fiction book, which was absolutely excellent. It's a story of a boy that had a disease that makes his skin look blue and, you know, his life, but actually it was excellent.
Interesting. Well, last question here. Where can people learn more about you and what we talked about today, as well as Dorsavi?
Yeah, probably the easiest way is on dorsavi.com. Or I'm happy to give out my email and maybe you can put it up, Mike, too. It's jgoldin@dorsavi.com if anybody wants to reach out to me.
And all links will be in the description, so you guys can look out for those as well. Joanna, thank you so much for coming on the podcast today. I truly appreciate it.
Oh, it was a pleasure. Thank you so much for having me.
Of
That
course.
was great.